Hello everyone and welcome to our podcast. I'm Rayhan. I'm a newly qualified junior doctor who's recently graduated from Imperial, and I'm starting my first job in Cardiff on the trauma unit. And the trauma unit here has a really good reputation as a pioneer of multidisciplinary collaborative team working. And on the unit I met with my supervisor, Professor Anthony Johansson.
Hello everybody. I'm Anthony Johansson. I'm a medical consultant. I've been working on the trauma unit for the last 30 years. And what I've tried to bring to the unit is less about medicine and more about the coordination of multidisciplinary working, which is central to everything we're going to be talking about.
And Professor Johansson has a YouTube channel, which is really good. And he has a short set of videos that discuss the care of older people who are admitted with hip fractures. And whilst me and Prof. Johansson were talking, we thought it might be really nice to package these conversations and share them with the world, but in the convenience of a podcast. And here we are.
Indeed. Hip fracture is a condition that's seen in every hospital in every country of the world. And we want to try and create something that speaks to people from different specialties, but also from different countries. Because the way in which health services are organised in different countries is hugely variable. But the frail and older people who we'll all see coming in aren't variable. They're the same sort of individual presenting to systems around the world. And what we're going to talk about will cover that.
Okay, and ward work will include getting people ready for an operation, but the rest isn't orthopaedics. And Professor Johansson, I want to ask, why are we focusing on hip fracture rather than any other injury or condition that might bring an older patient into hospital?
Well, I can argue that it's the single most important condition in healthcare.
That's not just because you specialise in hip fractures.
I'm not sure I'd necessarily win that argument, but we see 80,000 hip fractures a year in the UK. Those patients stay in hospital for an average of about 3 weeks, which means that 4,000 to 5,000 beds in the NHS are occupied by people with this injury. So it's a huge, huge impact. The cost of their inpatient care is about £1 billion. We lose around 6% of patients during the month following hip fracture. And of the survivors, only half will get back to the previous levels of independence. And that means that there's another £1 billion a year which is being spent on the home care of patients, or home care for patients who've not made a full recovery from this injury. So £2 billion on this single condition.
And obviously £2 billion is a huge amount. And with the population of the UK growing older, and we've got an ageing population, that's something that's been talked about for a while. How do you think that will affect the number of patients coming in with hip fractures, or just generally the care of elderly people here in the UK and around the world?
So another important fact about hip fracture is it's a really easily identified condition. There's no real argument as to whether somebody does or doesn't have a hip fracture in the way there might be about whether somebody does or doesn't have pneumonia or a stroke. It's very cleanly defined. So we've got really good data from the UK and around the world about total numbers of people who are suffering with this condition. And what we know from work we've done in the UK is that the ageing of the UK population, if people carried on having hip fractures at the same rate as they currently do, the ageing of the UK population would lead to a doubling of the numbers of people presenting with hip fracture in between now and 2060. Happily, people are getting fitter, so the sort of 90-year-old I look after now seems very similar to the 80-year-old who I would be looking after 30 years ago. People are fitter, and the risk of an 83-year-old having a hip fracture now is substantially less than it was back then. So happily the population is getting fitter, but not fast enough to overwhelm the ageing of the population. We're going to see major increases in hip fracture numbers around the world, particularly in parts of the world where the demographic change is the most dramatic. So
Asia,
yeah,
South America?
Yeah. Those sort of places are going to see a huge impact. And the economic impact of that on patients and on their families and on society in general is something that we're going to have to try and tackle.
And Professor Johansson, I know you've mentioned you're a doctor, but you look after patients who have hip fractures on the orthopaedic wards. Can you explain how that actually came about?
Yeah, it's really rather historical that the patients on orthopaedic wards are looked after by surgeons. If you dial back 200 years to Astley Cooper's time, he was a surgeon and he wrote a description of hip fracture, but he recognised that the management of a hip fracture was not something he could do. He recommended that you treat the patient and let the fracture go. It was all down to the quality of the nursing care that was provided to people with this injury back at that time.
And this would be in Florence Nightingale's time, so really letting the nursing care or the nursing leads take the charge.
Absolutely, and that was the situation in orthopaedic wards around the country, that essentially patients would come in, they'd have an operation, and then it was sort of left to the nurses to try and disentangle the rest of it. That was very much the situation I found when I first walked into orthopaedic wards in Cardiff, trying to find people who we could offer rehabilitation to in our own unit. Could we find people? We could find some people, but many of the patients there were very sick, were medically unsorted, or were just too complicated in many ways to be able to be disentangled. People with medical, psychological and social problems. And the interplay between those needed multidisciplinary workup. And understanding how to put that together became a real challenge for projects and papers over the time that I've been learning as a student and practicing as a doctor. And there were a number of descriptions where a surgeon and a physician or a geriatrician, somebody specialising in the care of older people, like Michael DeVas and Bobby Aveen, an orthopaedic surgeon and a geriatrician down in Hastings, working together, found that they were able to disentangle the care of these patients far more effectively than if they were just left to a traditional orthopaedic model. Michael DeVas said the surgical procedure must never be considered to be the whole treatment, but merely an incident in the general rehabilitation of the patient. He recognised, as Astley Cooper had recognised, that it's about multidisciplinary care, not about surgery.
And with the way medicine is going at the moment, with this podcast at least, I want to take a somewhat evidence-based approach. So not talking about studies a whole lot, but make sure we talk about the evidence. And how did the evidence come about for showing that medical management needs to be in these orthopaedic wards and for the care of our hip fracture patients?
Yeah, so much of modern medicine is built of randomized controlled trials, very expensive, very complicated trials with a very targeted intervention, and a new piece of metal for mending a fracture, or a new drug. Very, very easy to design that sort of trial. Trying to design something around the care provided by members or the whole multidisciplinary team is much more difficult. So that the literature around how these people should be looked after was built of small projects and papers written over the course of a number of years. Around the time I qualified, there were a couple of papers back to back in the BMJ talking about how collaborative working might benefit patients. They were RCTs. They wouldn't be published as RCTs nowadays, but they were just some of many papers that were published. But the challenge was that each of those seemed to study a different approach and a different model in a different hospital. And that was the chaos that you could see when I started doing this work, was that lots of people had done studies, but every hospital was doing something slightly different. Most hospitals weren't doing anything at all, but each of the trials were doing something slightly different. And when Cochrane tried to analyse all of these in 2001 and put together the overall impact of this sort of collaborative working, there was a suggestion that it was beneficial, but they really weren't able to quantify that or to make powerful recommendations as to what should happen going on from there.
So it seems that most hospitals aren't really doing much, but some innovative hospitals are trying approaches, but they're a bit different. how did we really move on from that and come up with a unified approach of this medical care into orthopaedics across the UK?
Yeah. So two people led a collaboration between the British Orthopaedic Association and the British Geriatric Society, the specialist societies. Dave Marsh was Professor of Orthopaedics in Belfast. Colin Curry was a geriatrician in Edinburgh. And they pulled together the two societies to do three different things. The first was that we ran collaborative teaching for trainees in both disciplines, simultaneously teaching two different disciplines in the same room at the same time. The second thing was that we wrote the British Orthopaedic Association Blue Book, which was a set of standards of care that we felt every patient should expect to receive. And the third thing, having created some standards, was that we started auditing each hospital in the country to look at whether they were actually successfully delivering that sort of care.
And as a medical student, I looked heavily into the NICE guidelines for my learning. What did the NICE guidance say about hip fracture care, and how was that implemented and when?
Yeah, so in 2011, the NICE guidance looked at all sorts of aspects of hip fracture care. So what operations people should have for which fracture types. Lots of detail. But the overwhelming finding from the NICE guidance is that we demonstrated that the presence of something called a hip fracture program of coordinated collaborative working for this group of patients. If there was a program, a structured program for that, looking at perioperative care and rehabilitation in particular, if that was in place, care was improved, patients got home quicker and became more independent.
And I know you've talked about the medical improvement that the NICE guidance implementation showed. Was there any economic improvement you were able to show?
Yeah, and the whole of NICE's ethos is that they have to show that it's financially worthwhile to do things. So normally you have to show that something's cost effective, that you're spending an acceptable amount of money to do it. That's not what we showed with the NICE guidance. The economic model there was that it just saved money. Good care is much cheaper than the previous traditional poor quality care, and very much cheaper in terms of the reductions in length of stay and improved independence.
And roughly how much cheaper per patient?
Oh, about £5,500 per patient.
So that's quite a significant amount. And I can imagine this probably gave some incentive to hospitals as well.
Yeah, so hospitals, you could tell hospitals about that, but it's actually very difficult to work out how you change your service to try and save on notional reductions in bed numbers and that sort of thing. That's really difficult to do. But NHS England took a completely different approach to it. NHS England said, well, if having a programme saves £5,500 per patient, we will pay hospitals to deliver a programme. So we'll take a set of standards, and if a patient receives care that meets those standards, we'll give that hospital £1,300 extra on the tariff for a hip fracture, because we know we're going to save £5,500 by doing so. And that meant that hospitals suddenly had the potential to earn real money immediately by delivering on care. And that care required that they put in place the necessary staff and people, medical expertise, as one of the standards that had to be met to deliver best practice tariff. And essentially across the country, every hospital had to meet these best practice tariff criteria of prompt surgery, prompt medical review, mental testing on admission, shared care, falls and bone assessment. And in recent years, we've added nutritional assessment, physiotherapy assessment, and delirium screening as necessary requirements to earn that money.
So it's a whole NDT approach, really, that hospitals really had to put in place.
Yeah, and they benefited, their patients benefit, and NHS in England benefit. We spend less money on hip fracture care as a result of that. So it's been hugely successful, and that's translated through in various ways. But the most obvious way in which it's translated through is between the start and now with that process. Mortality in the month following hip fracture has gone from 12% to 6%.
So that's a huge reduction, a 50% reduction in mortality.
Indeed, yeah. And what we need to think about in the podcast ahead of us is what are the aspects of care that underpin that change? How do we learn from what was so successful, and how do we explain that to the multidisciplinary teams in this country and around the world who are involved in trying to deliver that sort of care for the future? So there's a series of different podcasts that we've talked about putting together. I think understanding the relationship between the acute illness, the fracture, and the surgery for that fracture, that is a big package of acute stress on a patient. Understanding that and the context of a frail patient and how the injury and the frailty relate together is really important to designing care. Thinking about how we start the rehabilitation process in terms of therapy, how we maintain that in terms of patient nutrition. Understanding the challenges of dealing with people with dementia, the risks of their developing delirium, and thinking about secondary prevention with the sort of topics we need to cover.
And if we were to have an average patient who is, for example, listening to our podcast, what might they look like, or how might they appear? What sort of comorbidities might they have?
Yeah, so because not everybody listening to the podcast will be looking after people with hip fracture, so an idea of the sort of person we're talking about. The joy of medicine is that everybody is very different, and you can't make simple descriptions of individuals. But what we could talk about is what's the average sort of patient look like? Because the average patient will be very similar to older person coming into hospital with all sorts of other surgical or medical acute illnesses. And the challenge is she will be a she for hip fracture. 2/3 of hip fractures are in women. The challenges she faces and the problems that she has before coming in and while she's in hospital are very similar across many different specialties. So we'd be thinking about a woman. The average age of somebody presenting with a hip fracture would be 83, so she's in her mid-80s. She'll have a number of medical comorbidities, quite a few as we'll discover later. But half of patients have got hypertension. So she's probably got hypertension. She's probably had some end organ consequence of that, so maybe some heart disease or perhaps some stroke disease. And stroke disease may have had an impact on her memory, her cognition. That'll add to the challenge of looking after her while she's in hospital. Typically, a patient with hip fracture will be admitted from home where she'll have been living on her own, probably with some informal help. The majority of people don't already have some sort of formal care package. That's a sort of shape of the individual we would see coming in with hip fracture, but every other ward in the hospital will see the same sort of individual coming in with their conditions, their acute conditions. So they're going to face the same set of challenges that we're going to talk about in all of this. So that's our patient.
Our average patient. And do you think it's worth adding our patient as almost a third member of our podcast?
Okay. So running the National Hip Fracture Database, it's now run, the national audit is now run by the Royal College of Physicians. The approach we've taken in running that is to try and do everything to ask every question from the perspective of the patient, not from the surgeon's or the nurse's perspective, but what's the patient's experience. So we ought to bring her, you have to think of a name for her, we'll have to bring her in as a third voice in this podcast.
Does Grace sound okay?
That sounds fine.
Okay, well, welcome to our trio on our podcast, and I hope you've enjoyed listening. I'll make sure to include all the references, links to any studies we've mentioned, as well as Professor Johansson's YouTube channel in our bio. And again, thank you very much, Professor Johansson, and we hope you tune in for the next episode. Thank you very much.